Hello, everyone. I'm Nora Obuck with Edwards Lifesciences, and we'd like to welcome you to this afternoon's webinar, Beyond Insufflation, Hemodynamic Optimization and the Laparoscopic Procedures. And so while laparoscopic surgeries can be fairly quick and straightforward, physiology can become quite complicated with patients who have higher risk and have higher BMIs. Our two presenters for today are Dr. Michael Scott and Dr. David O'Connor. Dr. Scott is a professor of anesthesiology and critical care medicine at the Hospital of the University of Pennsylvania. He's chief of the surgical and neuroscience divisions of critical care medicine and is the medical director of the HPI Alert telemedicine ICU program. Dr. Connor serves as the assistant director of nurse anesthesia services at Memorial Sloan Kettering Cancer Center in New York. We do need to go ahead and disclose that both of our speakers are paid consultants for today's education. So I know we have quite a bit of content to cover over this next hour, and we'll try our best to review any of your questions at the end. So with that, we'll go ahead and get started. I'll turn it over to you, Dr. Scott.
Great. Thank you very much, Nora. Good afternoon, everyone. So I'm going to outline the physiological changes during laparoscopy. So the interesting thing is although over 2 million laparoscopic procedures are performed annually in the USA, there's actually surprisingly few studies that really truly look at the physiological consequences of pneumoperitoneum. So despite being labeled minimally invasive surgery, pneumoperitoneum puts unusual stresses on the body. And one of the things that's becoming more relevant in clinical practice is obesity leads to further issues. So I've just got a few slides here, which I aim to outline the key physiological issues for the anesthesia provider. So the way I sort of divide this, and I think this paper by Tamara Atkinson's group in Circulation back in 2017 is a very good way. You've got multiple effects across many organs, which are both directly due to the intra-abdominal pressure, but obviously you can have compounded effects if the patient factors are brought in, particularly cardiac function, pulmonary function, and obesity. And the physiological changes really depend on the intra-abdominal pressure that you use, the position of the patient, and what I mean by that is whether the legs are up or the legs are down for access, or the patient's on their side or not, which can happen in some procedures. Whether the patient is in Trendelenburg or reverse Trendelenburg. And then finally, the duration of surgery, because by having continual carbon dioxide pumping in and out of the abdominal cavity, particularly if it's not humidified, you've effectively got an ongoing metabolic acidosis with CO2 loading. And that's particularly important, I find, in patients who have got nutritional deficiencies, such as upper GI malignancy. And you get to this point 3.5 to 4 hours into surgery where your buffers have been saturated, and you can get a sharp drop in your arterial blood pH because of the CO2 is no longer buffered. So of course, with all these things, you've got to then make sure that your patient can have respiratory compensation. On the right here, this is nicely categorized in the increased intra-abdominal pressure and the hypercarbia and all the different effects on the different parts of the body. But I think this is the key thing, is splanchnic blood flow and hepatic artery blood flow can often be severely impaired, as can renal blood flow. And these are the things that manifest as either AKI or gut dysfunction postoperatively. My group back in Guildford at the Royal Surrey County Hospital and St Luke's Cancer Centre, we did standardized hemodynamic monitoring using non-invasive monitors for all major surgery. And this group of studies I'm going to show you is using a combination of arterial line waveform as well as aortic waveform and velocity. And what we were trying to do is we knew that in fluid optimized patients, so all these studies are in patients who've had oral carbohydrate drinks and after intubation and ventilation have then been basically put head down and see if they've got easily recruitable stroke volume, i.e. if the blood pressure goes down and the stroke volume goes down, we give fluid until nothing changes when they go head down. And then we do the pneumoperitoneum. So this is the effects of pneumoperitoneum in basically volume optimized patients. And you can see here that you get a rise in afterload. And what we tried to do was to see if we could obtain this physiological response using different drugs. And we tried GTN, remifentanil, and other vasodilators. And then we tried using sympathectomy, using epidurals and spinal anesthesia. And there was just no difference, basically, in the trends in all of these. And what this really showed is that the rise in blood pressure is due to increased aortic afterload. And this is a diagram here which shows the cardiovascular and ventilatory consequences of laparoscopic surgery. And you can see that basically you've got effect on cardiac output with stroke volume going down and a rise in right atrial and left atrial pressures. And this diagram here shows the effects. This is very diagrammatic. So obviously this isn't a sort of scientific representation, but I think it helps get my idea across that you've got this pressure both forwards and backwards and also upwards to the chest, with compression of both the IVC and the aorta, and loss of lung volume as you splint the diaphragm. And you can see in the head down position that now the heart's ejecting uphill against resistance, and you've got this reduced lung volume and increased weight on the lungs themselves. So when we actually mapped the outcome of all this, we found that in this position, the head down position, if this is the x-axis, which is time, and along here you've got your initial oxygen delivery in fluid optimized patients, so i.e. giving fluid didn't increase their stroke volume anymore. And then at pneumoperitoneum, you get this drop in stroke volume. Now in patients with normal LVs and SA1-2 patients, we found that they basically, firstly, they didn't drop so dramatically, but also they climbed back up the hill. And they sort of normalize at about 20 minutes. And I'm sure you all agree that this is the picture that we see in laparoscopic surgery. But what we found is those with impaired LVs, the ASA3-4s, not only did they not really compensate, they stayed below this line. And we mapped this as a risk factor. So an oxygen delivery less than 400 mils per meter squared per minute, you got increased risk of complications and an anastomotic leak. And it's all because the heart can't, the poor LV can't basically cope with the loaded circulation. So this is the way, again, diagrammatically to show this. So initially, when you got the abdominal, raised intra-abdominal pressure in the pneumoperitoneum, you squeeze blood out of the gut and the spine blood supply, so you get an increased venous return. And then you then get basically impairment of venous return, but you get increased aortic afterload, which basically then results in increased left ventricular stroke work. So going on to the respiratory issues now. So we've shown you've got diaphragmatic upwards displacement, which reduces your lung volume. You've got decreased compliance, so your ventilatory pressures obviously are higher. And you've got exaggerated VQ mismatch and atelectasis, but also importantly, dead space. Because when you've got a metabolic acidosis due to CO2 loading and you want to ventilate the patient harder and you've got increased dead space, it makes it more difficult because obviously you've got to increase your peak to maintain your FRC, your pressures are higher, and you get also the resulting effects on the right ventricular system and the pulmonary artery pressures. So you're increasing right ventricular stroke work to try and maintain your pulmonary physiology and your pulmonary blood flow to get rid of your CO2 and maintain oxygenation. So you can see that there's a lot going on. And then when you add in people who've got morbid obesity, the things get even worse. And I'm sure you're seeing this in your practice more and more. Certainly in my daily practice, we never really have an ASA 1 or 2 patient anymore. And the morbid obesity adds to the mix because you've got the pre-existing conditions, of hypertension, LV diastolic dysfunction. You've got a reduced lung volume FRC with lower chest wall compliance. And as you know, just poor VQ matching, just even ventilating someone with morbid obesity can be a challenge. And then you've got the problem facing the surgeon because you've got higher visceral fat, so they need a higher pressure to maintain their operating space. Now, we all do bariatric surgery, and of course this goes well in bariatric surgery because you're in the head up position, which basically creates space and you don't have the high intrathoracic pressures. But when you're in the head down position, I'm sure you all agree that this is a really big challenge then, because if you're a head down, you've got hypoxia and you've got the reduction in lung volumes, and then you've got even more pressure on the pulmonary side, which can really exaggerate pulmonary vascular resistance and increase right ventricular stroke work. So in the head down position, it really does challenge a morbidly obese patient. This table here, I think on the left, shows quite nicely the difference between head up and head down. The head up model is the hypovolemic model. The head down is the heart failure model. And then if you add in these three other risk factors, then things get very challenging indeed. So I've talked about morbid obesity, but obviously patients with CKD or pulmonary hypertension, all of this physiological response gets amplified and could lead to further problems or downstream postoperative problems such as AKI. So this is the head down position, and it really is, as I say, morbidly obese people, and we'll see this in our second example, that how much work is on both the left side of the heart and the right side of the heart. And that's what's key, because if you're not looking at flow and looking for these changes, then your patient can actually be part of the second group I showed, where you never maintain enough oxygen delivery around the body and you're more likely to get complications. And the other thing is with morbidly obese people with poor hearts is, I showed you that the normal response to pneumoperitoneum is to put your blood pressure up and the heart copes with the load. But often during prolonged laparoscopic surgery in obese patients, the heart doesn't cope with the load. And this is firstly manifested by a drop in blood pressure with the pneumoperitoneum. Then I think you know that you're going to be in problem. Of course, that's in fluid optimized patients. So it's really important that when we start laparoscopic surgery in these patients that we have fluid optimized them. And what I mean by that is you give fluid and see if the stroke volume goes up or not. We do this at my last institute by just basically either passive leg raise or tipping the operating table head down while the surgeon is draping and prepping. And then if the stroke volume goes up by 10%, we would give a 250 bolus. And if it doesn't, then we fill with fluid optimized. And most patients will need 750 to a litre, about 10 to 12.5 mils per kilo. But what do you do if you haven't got a patient who can cope with this afterload? Well, obviously one option is to do open surgery, but because we know that open surgery has other effects, we're starting to look more and more now at ways that we can get patients through this and support the heart. So we can support the left heart with basically any type of inotrope. None of these are more evidence-based than the others, and obviously some have purely beta effects like dobutamine, some have more alpha effects like norepinephrine, and some are more mixed, such as epinephrine. We can ask the surgeon to reduce the intra-abdominal pressure. That's certainly more likely with robotic surgery, where it's less likely to impinge their basically angle of attack or their space. We can make sure our patients are paralyzed and monitor that and make sure they've got deep neuromuscular block. And meanwhile, if we've got other changes, it's important to keep up with volume, and it's important to make sure that we have got basically a minimal cardiac output and oxygen delivery, so that we know we're not going to push this patient into the complication zone postoperatively, particularly on the 3, 4, 5 hour procedures.
Okay, so this first case is a 58-year-old female with known diverticular disease for laparoscopic partial colectomy, a low anterior resection with anastomosis. In this case is a possible open, like they all are. She has had previous abdominal surgery for diverticular disease in the past. And so the surgeon is estimating a 30 to 50% chance of needing to open for this procedure. She has other history of well-controlled hypertension. She's active, she plays golf, she goes to the gym. She did get a bowel prep and has been on sips of water since midnight and with a carbohydrate drink preoperatively. So overall, not a horrible specimen. So I'm going to roll the tape here. We rationalized the clear site on this case. This is non-invasive monitoring, and I'm always happy to put those on right when the patient comes in the room. That way, I know I have good placement of the little bladder around the finger, and I get a baseline. So this is our induction of anesthesia, and we can see where she is with all of her faculties and ability to compensate that we properly take away with our induction. So we know she had a bowel prep. So I'm inclined, and Mike, feel free to chime in anytime, to open my IV up and let it run for this kind of a case. And for most cases, people come to the operating room dehydrated. So I may not.
I think everyone needs 500. I think you can give 500 before you start really titrating, don't you? And Relief really showed that.
Yeah.
Because they're giving 750 to a litre. You need the fluid up front before the physiology of positive pressure ventilation and the pneumoperitoneum. So I do the same. I give 500 and then start seeing if they're fluid responsive to head down or passive leg raise.
Sure, and it makes sense. And like you said, we have a limited window of the time between induction and insufflation, and we really want to do our best to optimize the patient before those changes happen. So we have, we've set ourselves up for success. So you can see here our mean arterial pressure has taken a bit of a dive. It's supporting the idea that the patient's hypovolemic because our SVV is up. You can look at the trends of the stroke volume. Cardiac index is, still in a safe zone. But we just started a crystalloid bolus there. For me, it would be right when we first start. So now we have that vulnerable time between incision and between induction and incision, but we're taking advantage of that right now by fluid optimizing our patients. And at some point here, we can get an idea, we can assess one of the nice things about the flow track is you can look at, as long as you're marking where, or either mentally or on the flow track, where you've initiated your intervention, you can look at the percent change over time with a simple touch of the screen and see if the fluid that you're given is in fact making a difference. And in this case, we want to see a stroke volume change of 10% or more. Serves the same purpose as the passive leg raise. So we can tell if the patient is on the steep part of the Frank-Starling curve.
Yeah, I like your thinking here, Dave, because we do something similar. Really, all you're doing is trying to get the patient back to their baseline because that's the normal pattern. So it really doesn't matter what this number is. It can be apples or bananas. It's that, you're getting the patient back to 10 bananas if that's what they started at. I find that a lot of my colleagues get a bit overly worried about the exact number. I think the numbers are important, but at this first stage, we're just trying to set the patient back to baseline after they've been ventilated with positive pressure and all the physiological upset that can lead to.
Absolutely, and we know what's coming, so we want to put them in the best position we can put them in. And here you see the parameters are, it says 7%, but if we slide that, we're going to slide those over in a minute, and you see it's 12 right before it went dark there. We had a 12% change in stroke volume, and you can look at the trends. And by the way, there are a number of different screens you can use, and some people like the little beating heart, but I think it's the most the best way to look at these numbers is in a trend, so you can see where things have been and where they're headed. And you can see here that the SVV is heading down. Your mean arterial pressure is hovering, but moving into the right area. And we definitely can tell that we have a significant increase, or enough of an increase to rationalize giving more fluid of the stroke volume. And,
yeah, I think in real day practice, we often give small boluses, don't we, of phenylephrine or ephedrine while all this is going on, because we don't want to wait necessarily 10 minutes to get a fluid bolus in and have hypotension for significant time. And as you say, then everything starts sorting itself out, and the patient tends to then fall into a steady state, which is, I think, what we're seeing here.
Right. And here comes our insufflation. Yeah, I'm often asked if it's okay to do more than one intervention, and I prefer to do one, so you know if it's working. But you know, when you're looking at a mean arterial pressure and the evidence showing that if you're under 65 for any period of time, your patients are prone for poor outcomes, then you're certainly going to do anything you can to get that pressure back up to the safe zone. In the meantime,
so we're starting to see this blood pressure rise that I was discussing, aren't we, with the increased aortic afterload?
Yeah. And then you have a decrease in preload that may mimic the hypovolemic state that we're looking at. Stroke volumes coming down. So what do you do here, Mike? Are you going to treat this?
No, I think this is the point where you just have to ride this out, because we know the patient's already fluid optimized.
Right.
We know there's some strange things. You know, blood is being forced out the venous circulation in the first instance, and then we've got reduced venous return. And meanwhile, we've got a raised afterload, which we've shown is hard to really deal with drugs or even a sympathectomy. It's hard to, but at 20 minutes, things tend to settle down. What the physiology of driving that is, I don't know. But presumably there are changes that the body makes to improve blood flow. And I think if it just sort of doesn't go up too high, then I just ride it out. What do you do?
I would do the same. I'd be inclined to do the same. But what I was just thinking also is that these cases, at my institution, they're doing tap blocks. If there was a high chance of opening, they might put an epidural in. So then you've introduced another variable into the scenario of vasodilation associated, because we run a high dose bupivacaine now. Right off the bat, we might even put some fentanyl in the epidural. And it's not indicated here, so I guess we can assume that's not the case. But that's something else that common practitioners will have to take into consideration.
Yeah, well, that's what's interesting about our work is it showed that it didn't actually obtain this initial hypertension. But you're right, the problem then comes downstream at half an hour. Is if you're not careful, you've got veno and arterial vasodilation, which throws further complication of the physiology into the mix, doesn't it?
Yeah, and then you throw some Precedex up there. You want to do the perfect cocktail.
So now we're seeing, I think this is a sort of a real sort of life, isn't it? Now we're just sort of edging back down again.
Yep. So the compensation is, patients normalized to a degree here.
And I think if the sort of amount I'm seeing here is if there's no stimulation is one thing, but if there's stimulation and we're seeing a change in blood pressure going down here now, I'd be worried about blood loss, which I think is what is actually programmed into the scenario here. So,
so that's, not that all bets are off, but you want to replace blood loss with, whatever your choice is. And I don't have her starting hemoglobin and hematocrit, but I'm inclined to just throw some alkaloid up and run that to try and match the blood loss until we get to an area where we would have to transfuse.
Yeah, and I'd be giving a little bit of ephedrine as well and phenylephrine, possibly just to stress the circulation and maintain central flow. Because we've got 3 indices here, haven't we? Stroke volume's dropped, SVV's gone up, and MAP's gone down. So I think this is volume till proved otherwise, but we need to buy a little bit of time while we get that volume in.
Yeah, I think what happens here is there's going to be a crystalloid bolus. But again, if it were me, I would definitely, I agree with you. I would be treating that mean arterial pressure with some kind of pressor to get it up.
And I'd be talking to the surgeon as well, obviously, and just seeing what's going on, really.
Yeah, that's one thing that you know, a lot of times in discussing how to manage a case that kind of gets overlooked. There should be a open dialogue with the other side of the drapes or the other side of the machine or wherever the robot is being driven from.
Yeah, I think the other thing in laparoscopic surgery, smaller blood loss volumes can have a bigger impact on your physiology because of, you know, you've got this intra-abdominal pressure, which can often reduce your venous return at the time. And as I say, also, you've got this aortic afterload. And sometimes if we can overdo the anesthesia gas or something. And so when you're hypovolemic, you get a more exaggerated response. So, which is why the monitoring is good, because you can track things and pick things up early.
Yeah, I agree. And you can lose a fair amount before you become symptomatic. So a lot of the bleeding in these cases is not overtly apparent. There's a lot
Going for another bolus here, which I think is very sensible.
Yeah, we're looking at the difference again here in the change over time made a difference. So that's a second crystalloid. The problem I'm having with this right now is that mean arterial pressure is sort of hanging down there, and we've been saying it for the last few minutes here that we'd be inclined to treat that.
Yeah.
Look at your cumulative time below 65. You know, this woman is otherwise healthy, but in the next scenario, that is not the case.
Yeah. What volume do you use for your boluses when you're at this stage?
I'm at 250 now. Yeah.
Yeah, I agree. I tend to start with 500 at the start of the case, and then I'm a 250 person.
Yeah.
Unless there's obvious ongoing blood loss, in which case sometimes you've got to keep up with it.
Right. Yeah, 250 does the trick. And if I'm giving colloid, that's what it comes in, so that's convenient.
So we're getting better here, aren't we? The SVV's improved, stroke volume is coming up, and MAP's coming up.
Yep, trending in the right direction. And I think that, you know, for the purposes of this presentation, we've accelerated the amount of time this case took. And our next trick will be normalizing the patient here at the end.
Yeah, that's right. I think that's important too, isn't it? Because the legs go down, the gas is out. If you think if we've been head down and legs up, then we've had good venous return sometimes. And then we flatten the patient out. And I think you normally reveal hypovolemia and need to give another 250 or 500 bolus at the end.
Yeah, and you know, at my institution, we have a low threshold to throw up a phenylephrine drip. And, you know, when they start to close, everybody wants to get that off and bring the patient out all nice and tidy. And then you put the legs down, and just like you say, it's an uphill battle. Might behoove you to leave it on a little bit longer, or at least until you get the volume back to where it should be.
Yeah, and then as you can see here, we're sort of just coming back to baseline. And now time for desufflation.
Yeah. So the stroke volume variation came up, you know, also your mean arterial pressure. So at this point, I mean, I guess we can wait for the next, see where the trend is going. But I mean, in the back of my head, I'm thinking I'm going to need to give some fluid here.
Yeah, I mean, a lot depends whether the legs have been up or down, and whether you've been head up, head down. And of course, your depth of anesthesia as well. So.
Right, same time you're waking them up, so they're coming back with their compensatory mechanisms and all of that.
I try and encourage our residents to basically keep monitoring till we've really got everything back to normal, because everyone wants to take the monitors down just before your legs are down and the gas is out, because they think it's game over. But I keep saying, well, this is useful information to try and get everything back to normal.
Yeah, why? I don't see the advantage to unhooking them from the monitors until you're ready to move them onto the stretcher, you know, and I would even argue that you should bring this out into the recovery room and have them, you know, take over from where you left off.
Well, I think that certainly when it's non-invasive like this, it would make obvious sense, wasn't it? Especially now the data shows that there's hypotension and concealed hypovolemia in the postoperative phase.
Yeah.
Good. So I'm going to go on while Nora loads this next one up. So this next one's, I think the first one we demonstrated that we fluid optimized before the pneumoperitoneum, that we got the hypertension of basically the afterload of the pneumoperitoneum. And then basically it sort of went back to normal by itself. And then we caught up with blood loss, and then we re-optimized at the end. This one is going to be more challenging because we've got a 78-year-old man who's got morbid obesity with a BMI of close to 50. He's having a laparoscopic right hemicolectomy, possible open after a adenocarcinoma found during colonoscopy. He's got limited mobility, so it's hard to assess him clinically, although he can walk 1 to 2 blocks, but he's a smoker. He's uses a CPAP machine for sleep apnea. His EF is 55% with grade 1 diastolic function and mild TR, but I always worry about that, do you, Dave? Because it's not a loaded test, is it? It's just a resting test.
Yeah.
And he's got diabetes. He's on amlodipine, losartan, aspirin, pantoprazole, atorvastatin. So a pretty typical sort of ASA3 patient that we do every day. He's had bowel prep, been starved for food from midnight, but has had pre-op carbohydrate loading both the night before and the morning of surgery. So he's on his 0 hours protocol. So Nora, I'm going to ask you to drive this one, if that's all right, so that I can sort of look at the numbers. So we're just getting here, so ready for induction. And we've got I've put an A-line in this guy because he's obviously, I consider high risk. And I'm trying to get, like you were, Dave, a baseline here. So stroke volume of 63 or whatever you want to call it, 10 bananas. So that's what I'm going to try and drive him back up to. He's got this sort of high baseline map. That's because he omitted his losartan. It's often what we see, isn't it? And then they crash their blood pressure if you give it to them. So it's real life, really, with these hypertensive hearts and these morbidly obese patients. So, right, I think, I'd like to induce anesthesia now. So I think we'll get there. Good, excellent. And I'm not expecting too many problems here because his resting EF is 55%, but I think what we might see is an exaggeration to the physiological response of positive pressure in his chest because he's got all these other problems going on. I wouldn't have minded some blood gases on him either with this. It's interesting with this smoker and being on CPAP, it does make you wonder how much pulmonary disease he's got underlying there. And already we've got a little bit of a signal, haven't we, of cardiovascular instability on induction. So the map's dropped, which is realistic, isn't it? I think because he's got an intrinsic hypertension and his SVV's gone up, so his preload's been affected, and his stroke volume's starting to go down. And these are things I think we'd normally pick up with basically intubation. Would you be treating this at this point, Dave?
Aside from the bolus of fluid, I probably wouldn't be yet. And it's interesting though. This isn't somebody that I would go easy on an induction with either. Would you cut back on your induction agents here, or?
Yeah, I would actually. Yeah, I'd probably be a bit more heavy on my fentanyl.
I don't routinely give fentanyl unless they really need it. So that's something I switched when we went to electronic charting. But so this guy would have just gotten propofol from me unless he declared himself somebody who needed an opioid.
Like you said, I've got a 500 ml bolus going in as just want to get that in because he's going to need at least that. And I go on his ideal weight of 70, 80 kilos. So I'd be wanting to give this guy 750 really to a litre before we get going. And things are sort of stabilizing, aren't they now?
Yeah. Good.
But it's not ideal, is it? We've got a stroke volume which is down. a map which is okay, but a high SVV. So this is a heart that isn't particularly happy. I think the real question is would you start a big 4-hour case with figures like this? I think I prefer to get it, wait and give another fluid bolus, would you?
Yeah, I think he needs to be optimized a little better before going ahead.
Okay, let's give another fluid bolus then and see.
And we can see the first one did some good.
Yes, that's 500. So this will be 750. This is where I start going to a 250 bolus, do you?
Yeah.
Although having said that, an extra 250, I think even in someone with a diastolic heart failure probably isn't the end of the world. I think you're better off being that little bit too much than under, which is what Relief showed, the Relief study I'm referring to, everyone. So I'm just hoping, oh, well, there you go. So stroke volume's going up a little bit. Yeah, so we're getting back, his baseline was 65, wasn't it? So we're there or thereabouts now. And his SVV's down. So I think I'd be saying to the surgeon, it's probably time to get on with it now, would you?
Yeah. Yeah, I think
we've got his flow's back to reasonably normal. He shouldn't be too preload responsive with an SVV less than 12%, and he's got a good map. So
we give the green light.
Yeah, so there we go. So the surgeon's insufflating now. And I'd be watching this like a hawk. I'd certainly be in the room looking over the blood-brain barrier. Yeah, we got an immediate signal in here of the LV not being happy. SVV's gone up with the blood pressure going down. So I worry when I see this. I think this is a sign of the left ventricle not being able to cope with the afterload.
Yeah, look at that stroke volume.
Oh yeah, and that's tracking it now, isn't it? And this is one where I'd be again talking to the surgeon, and I'd be saying, just hold on with the pressure you're going to insufflate to, because sometimes they want to go up to 16 to 18. I'd be saying, can you just hold it at 12 for a second? Just while we stabilize, and I'll be giving some ephedrine here, I think, just to support the heart. What would you use?
I would probably use Neo, but
okay,
that's just a preference. But we sort of are driven by heart rate, and
yeah, I see what you mean. Yeah, I think the main thing is give something, isn't it? Because we know it's not fluid, because we've already given the fluid and sort of got him back to baseline. And I think this shows a case where it's so useful getting your figures before you start, isn't it? And knowing what the patient's normal values are. So yeah, this isn't looking good, is it, with the pneumoperitoneum? So we're getting through a bit of a rocky patch here. We've got a reasonable map though, so we're going to be maintaining perfusion, but we've got huge SVV. We can see the swing in the A line, and the stroke volume is at that level which I showed in that graph with our data. It puts this patient at high risk. So what would you do at this stage?
I think some fluid might be in order.
Yeah, I agree. I think we always want to give an extra bolus of fluid before you start pressing the circulation, because we know otherwise you just steal from the splanchnic blood supply. And I think it's hard to know, isn't it, with people? They're all different shapes, and people take different volumes. So that's one of the things I realize when you monitor every patient every time, people come in different shapes and sizes and different abdominal sizes compared to their height and things. So it's always worth making sure you're fluid optimized first before you press them.
Yeah, and we didn't see that normalization after 15, 20 minutes that we did with that other case in this.
No, absolutely.
And I suspect you wouldn't expect that.
Yeah. So that fluid does look like it's helped there. Our map's sort of above 65. Our stroke volume's not normalized, but it's come up a bit from that danger zone, and we've still got a high SVV. I always worry now, though, going into the head down, what's going to happen to the right ventricle as much as the left ventricle here. And this is what's going to happen now. So we've just about able to get through with him with a pneumoperitoneum, but now we're going head down. And so now we're into that physiological position where we're head down and the heart's ejecting uphill against resistance. So this is another stressor for the left ventricle. And at the same time, there's the right ventricular stroke work going up because we've got increased intrathoracic pressures with the weight of the abdominal contents on the diaphragm.
Yeah, and look at the set.
Yeah.
So the other thing you need to consider is what's happening in that thoracic cavity.
Yeah, I think I'd be phoning you to take over this case at this point, Dave. Yeah. Okay. So we're back to where we were on the scenario now.
Yeah. So now
I'd be supporting the heart here, wouldn't you? With the, I mean, a pen, we would use a peripheral epinephrine infusion.
Yeah, we would use dobutamine or norepi, and neither of those is in the room with us, so we would call for it, and someone might give some calcium just to see if that helps tide us over, or if you know that's going to happen, maybe you get it ahead of time and you hook it up. That's
I agree. I'd certainly be giving, I think it doesn't matter really what you give as long as you're supporting the heart at this stage, because otherwise you can end up with 20 minutes of quite profound hypotension. And also, your coronary oxygen delivery will be reduced with that lower MAP. Here we go. This is an epi infusion, I think, because we've got increased tachy and it's put both heart rate and MAP up. But
wonderful.
So should we just ride this out and wait? We've obviously had a bolus and see how this bottoms out.
Yeah, I think now, I mean, I'm concerned about the stroke volume, but my mean arterial pressure is in a good zone. And he started kind of low anyway. It's creeping up.
I think this is often a sign the right heart is not happy.
Yeah.
Because we know we're fluid optimized and yet our stroke volume's down and we're supporting it. So we've got a problem of blood going from the right side into the left side, which is often a sign of pulmonary problems and high pulmonary vascular resistance. Which is why sometimes people say epi is better than norepi in these patients, I think. But I think the main thing is to support the circulation. So I think this is just going to show now desufflation, and hopefully we'll get back to where we were.
We've gotten them through the case. That's the deviant norm. It's considered success.
Yeah, well, that's the thing, isn't it? Is you've got all the problems of open surgery. So although it's easier for us in the OR, it's harder for the patient post-op. So I don't think we've really got strong evidence, have we, of the risk benefit in these cases. But certainly, I think if you can get them through like this with low dose vasopressors or epi, it is worth it. It'd be useful to have a study on troponins release, wouldn't it, in these cases?
Yeah. Looks like he's migrating back to his normal.
Yeah, it's amazing, isn't it? You take that physiology away and everything gets back to normal. And I think that's why surgeons know if they can do it laparoscopically, it is better, because now the patient's going to make a much better recovery.
Yeah.
So although we've stressed them for a short time, we've done it under controlled circumstances with you and I at the top end and everyone on this call. We managed to get the physiology controlled. Whereas with open surgery, effectively, we've got a big stressor and the patient's going to the floor for 2 or 3 days and having the same sort of stress in an uncontrolled way. So I think this is why laparoscopic surgery and supporting the heart in these difficult cases is so important now. And we need a lot more work into this, don't we? A lot more studies, I think, to try and work out the best way to do this.
Yeah, I think, and if we're all using all of the tools in our arsenal, the transient derangement is something we can get the patient through. And like you said, it's better for them on the other side of it.
Yeah, But I do think these high risk cases, I find the monitoring the most use in, like here. I think it's done because if you're not watching it, you can't really tell flow from the blood pressure. That's the problem, isn't it? So you don't always know which arm to tackle, whether it's fluid, contractility, or afterload.
Yeah.
Good. So we've got him through that. So that's good.
Looks like we gave some fluid there. Yeah.
Yeah, again, I think the same principles, isn't it? Optimize, start in the middle of the road before the pneumoperitoneum and all the physiology. And then at the end, once the gas is out, the legs are down, re-optimize again. Thanks, Nora. You were really challenging us with the second case, I can see.
I'm going to speak a little bit about this Acumen Hypotension Prediction Index software that Edwards offers, and I've been using for quite some time now, year and a half, maybe a little more. There was obviously a dramatic pause during COVID, but this is a machine or software that gives you one more screen to help you manage your cases. There we go. So for those of you who are not familiar with it, the Acumen software is predictive monitoring, and it gives you this HPI hypotension prediction index number that is an indication of the likelihood of an incident of hypotension. And in addition to the other numbers that Mike and I were using to manage these last two cases, you get these other numbers that show you, this is afterload EA-dyne. It takes the change in pressure and puts it over the change, the variation in volume, and can help you to determine whether the patient needs fluid or not. And then over here, DPDT is contractility. So if you're considering an inotrope, these are very helpful numbers there. This is just another look. So the HPI here they're just sort of saying what I just said. This is the alert that comes up. Once this number hits 85, you get an alert, and then you can take yourself to this page, the secondary screen, by touching more information, or just acknowledge it if you already have an idea of how you're going to act. But taking a look at these numbers is very helpful, in addition to the numbers that Mike and I were using on these last two cases. So we have stroke volume variation. There's also pulse pressure variation as an option on this that we don't have on the other machine. And then the number here is literally the PPV over the SVV. And if it's one or more and you're hypotensive, then fluid might be the answer. And then you can look at your contractility here and see if you could give it a kick with an inotrope. Or if the issue is more imminent, you can use a vasopressor. So this is a case I actually did, and I just took a screenshot. This was a case that we did back in December, a 77-year-old male who had a robot radical cystectomy with an ileal conduit. He had a positive stress test. He came with bladder cancer, hypertension, and all the things that people that have bladder cancer come with. And this is a case that we did everything. We managed with fluid at the beginning. We ran a phenylephrine drip to keep the pressure above 65. This happened to be a snapshot of not the best part of the case. And here you can see he probably needed some fluid also. We did support him with an inotrope. We used, in this case, we didn't have it in the room. So we did what I was saying earlier. We ran, we slowly titrated in some calcium, and then started dobutamine at 2 mics, and then kicked it up to 4. And that's when things sort of settled out for him. And you can see here, again, my favorite screen, looking at trends. We brought him back into a favorable area after surviving some of this HPI exceeding the high limit for a fair amount of time. His mean arterial pressure was also taking a hit here. But we brought him back up into the comfort zone with a little medication experimentation, I don't know, and some fluid. So that's sort of HPI in a nutshell. And you know, it's very helpful. We use it in open cases. We use it in minimally invasive cases, wherever we feel it's got a its use would be helpful. There's a niche. We're using it in some of the big thoracic cases, the esophagectomies, our big debulkings in GYN, and where there are big fluid shifts, and it really helps you manage the case, improves your ability to see the big picture.
Yeah, I like the secondary screen on it. It's fill flow pressure again, so you can map your stroke volume and your SVV, you know, if they're going to respond to preload. It gives you that contractility, doesn't it? So you know, contractility doesn't tend to change too much in most patients, but at least it gives you a nice signal if there is a contractility issue. Because then I tend to just fix contractility with a low dose beta agonist, you know, dobutamine or epi. And then all you've got to do is basically balance your preload and afterload, which is what you're doing, wasn't it? With looking at the preload and then the SVR. So it's great.
Yeah, it's just a matter of getting buy-in from everybody, and you know, judging from that poll we gave at the beginning, where you know some practitioners are disinclined to use dobutamine or an inotrope because it's culturally not something they do. It would be interesting to see how the cases do if that sort of thing was introduced on a more broad level.
Yeah, I think it's very positive though, isn't it? Because if we'd have done that poll 3 or 4 years ago, I think the figures would have been very different. We'd have probably have at least half of people wouldn't be using vasopressor or infusions in the OR, and now they are, which is great.
Absolutely. And then the question is, do you shut them off? Do you want to bring that tidy patient out to the PACU, or do you think that it's, you know, worth leaving on and carrying over? It is perioperative fluid management after all.
Yeah, I think that raises, so back in the UK where I was in Guildford, we did basically 12 hours of flow directed therapy for every single patient having major surgery. And we continued whatever type of monitoring we were using and combined that with bedside echocardiography. And again, used the fill flow pressure, made sure that they were optimally filled, enough flow, and then balanced the circulation with low dose phenylephrine or norepi. And I think that's one of the reasons why we had such good outcomes with such low AKI and sepsis and delirium. So you're right, it's how we fix this, isn't it, in a US health system where there isn't payment for this post-operative intervention unless the patient goes to ICU.
Right.
And even then there's questions on whether this gets, because it's all considered anesthesia care, if it's just optimization rather than actually treating patients for true sepsis. So it's food for thought, isn't it, as we move forward in the next 5 years, and how we change culture, change the payers' attitude to this, to basically put quality first, which will ultimately drive down complications, improve patient satisfaction, and then actually ends up driving value, because quality will drive value in the end.
Yeah, agree.
There was one question that I answered from AJ. It was just about how I give my vasopressors, and I just said, well, I tend to, with phenol and epi, well, normally I would reach for some phenol stick and see what the response is, and often put up a phenol infusion. I think most cases have a phenol infusion in the OR. And epi, if that's failing and I think the heart needs support, I normally start with some epi pushes because we have epi sticks, but then I'd have to get a drip to run that peripherally. As I say, back in the UK, we use norepi and dobutamine. So there's many ways to fix it. The main thing is to fix it and get the right fix.
Yeah, I agree with you. I think that one of the other things that Acumen software offers is the ability to look at your cases in real time. You can see the cumulative time, how often and how long you're under that 65 mean arterial pressure. And I think that because of the evidence that's come out in the literature, we all have a very low threshold to take action with a neodrip or an inotrope. And as long as this is being driven by the evidence, then I think that the culture change you're talking about is imminent.
Yeah, there's another question out there by Sumin Un. I hope I've pronounced your name correctly. Apologies if I haven't. Does this work only on intubated patients on positive pressure ventilation? So you've highlighted an important point about stroke volume variability and pulse pressure variability, where effectively you need a tidal volume of at least 8 mils per kilo to give you real sensitivity on those. But these machines, I have used them in spontaneously breathing patients, because what I then do is, rather than looking at SVV, I just track the stroke volume and the map. What do you do, Dave, if they're not ventilated?
We, as a group, we've sort of gotten away from looking at stroke volume variation and making clinical judgment solely based on that. We incorporate stroke volume into all of our decision making, and I can also tell you that with the Acumen, I don't mean to keep touting this, but the Acumen software, that EA dyne that is based on that stroke volume variation and pulse pressure variation, the ratio is not affected by whether the patient is ventilated or not. So if the EA dyne is 1 or more, you would give some fluid if the patient's hypotensive. So, but I think that the idea of keeping the patient on these machines in the recovery room when they're breathing on their own is important, because you want to get buy-in from them too. You don't want to have, we've done so much good in the OR and we brought them out and they've just flooded them in the recovery room, and that's a tendency because of the culture.
Yeah, and I think that's why I like the fact with using the non-invasive one, you've got a baseline, and like why I get a baseline if I use an arterial line, because that's the patient's norm. Or if you give, or you can challenge them and find out where the sweet spot is for them, and that's where you really want to take them back to at the end of surgery and in the PACU. And you're right, rather than just using single figures for optimization like SVV or PPV, you're looking at the whole picture. And if the flow is normal and they've got a normal map, then by definition they've got a balanced circulation. So it makes life very easy then.
I think that's a great explanation, and also a really nice way to wrap up this discussion. We're just a little bit over time, but just really want to thank both you, Dr. Mike Scott, Dr. Dave O'Connor, and especially everyone who took the time to join us this evening. Thank you so much for your time, and I hope you were able to learn more about how you can kind of incorporate some of these advanced parameters into your practice, especially into this more high-risk laparoscopic procedure. So thank you so much.
Yeah, and please all give us feedback, because it would be great to know what else you would like to know from the practical use side of using these machines in the OR, and then, as Dave says, in the PACU area as well.
Excellent.
Great.
Thanks so much, guys. Hope you all have a great night.
Thank you. Pleasure.
Thanks. Take care.
Okay.